Ladies and gentlemen, thank you for standing by and welcome to COVID-19 Media Briefing Conference Call. At this time, all participants are in a listen-only mode. After the speaker's presentation, there will be a question and answer session. To ask a question, you will need to press star 1 on your telephone keypad. If you require any further assistance, please press star 0. I would now like to hand the conference over to your speaker today, Michael Schrumer. Thank you. Please go ahead.
Thank you for joining us for the COVID-19 media call for July 10th. We'll start today's call with a situation report from Health Commissioner Jan Malcolm and Infectious Disease Director Kris Ehresmann. We also have MDH Office of Health Facility Complaints Director Lindsey Krueger on the call today to help us share news about some new guidance we're releasing today related to essential caregivers in long-term care facilities. Lindsey is joined by 3 representatives of the Minnesota stakeholder groups that helped us develop that guidance. This includes Cheryl Hennon with the Minnesota's State Long-Term Care Ombudsman, Gail Kvenvold, President and CEO of Leading Age Minnesota, and Patty Cullen, President and CEO of Care Providers of Minnesota. After updates from each speaker, we'll turn it over to questions from reporters on the line. With that, I'll now hand it over to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. As of early this morning, around the world, we were approaching 12.3 million cases of COVID-19 and 556,000 deaths from this disease. In the United States, as of this morning, we were over 3.1 million cases and 133,000 deaths. In Minnesota, we are announcing an additional 609 confirmed cases from yesterday, bringing our cumulative total to 40,767 laboratory-confirmed cases of COVID-19 in Minnesota. I will note that is the largest case total we have seen since early June. However, we are certainly testing a lot more people than we were back then. I'll comment a little further on testing in a moment. The median age of our cases continues to drop. It is now 38.1 years as of yesterday's total. And I believe the daily median age yesterday was right about 29 years old. Unfortunately, we had an additional 5 deaths in Minnesota yesterday from COVID-19. 3 of these persons were in Ramsey County and 1 each in Hennepin and Olmsted. These were 2 individuals in their 90s, 2 in their 60s, 1 in their 50s. One of these persons was a resident of a long-term care facility. Currently, there are 227 patients in the hospital, 124 of those in intensive care. The increase of 8 people in intensive care yesterday was the first time we'd seen an increase in intensive care in a number of days. As I mentioned, yesterday's total of 609 new cases was on a very strong, the strongest yet, volume of laboratory confirmation of tests. That was 19,213 lab tests processed yesterday. The 7-day average testing positivity rate, which, as we've been talking about, is an increasingly important measure for us to track, given that we are testing so much more. It's the percentage of those increased tests that are positive that we're really keeping an eye on. That 7-day rolling average positivity rate is now 4.5%. Which is an increase from 3.8% a week ago. Over the past week, we've seen an increase in total number of tests of 12.5% compared to an 8.3% increase in new cases detected over that same week's period of time. This week, we passed the milestone of 700,000 COVID-19 tests having been performed in Minnesota overall since the beginning of the pandemic. I just want to once again thank all of the partners that have helped to make this possible. The health systems, the frontline workers in clinics and long-term care facilities, hospitals, community testing sites, the National Guard, our partners at the Mayo and University of Minnesota for helping all of our health systems increase testing capacity in Minnesota. This is, as you've heard the governor say many a time, such an essential tool in our ability to manage the disease going forward in Minnesota. I'd like to give you an update on something we talked about last week with Dr. Linfield and Dr. Hick, and that is about the drug remdesivir. We are very grateful to the Gilead Company and the Federal Department of Health and Human Services for what they've done over the recent weeks in facilitating the supply of donated remdesivir for patients in Minnesota. Since Dr. Linfield reported on this, I think it was just last week, we have learned that the donated program has ended, and the program is now moving from that fully free program to what the federal government is referring to as a semi-commercial model, where allocation and distribution of the drug will still be managed by the Department of Health and Human Services federally and by the Minnesota Department of Health. But going forward, hospitals will be expected to purchase this drug if they wish to use it. The State Health Department continues to work with our ethics group, which is made up of ethicists, clinicians, and we are working closely with that ethics group, with frontline physicians and health system leaders to determine how best to manage this new process. We will still, from the health department's perspective, still be allocating amounts to hospitals based on their total numbers of hospitalized cases, but the hospitals will now be deciding whether or not to purchase all of that allocation or just part of it, or however they make that decision at the hospital level. The first shipment under this new process is expected next week. The allocation model has not changed from the federal government, so they are still allocating to the states based on the total burden of hospitalized cases in that state. We've been talking with hospitals around the state, and we're hearing from them that in general, the facilities are fairly comfortable in terms of the supplies of remdesivir they currently have, as our total numbers of hospitalized patients has been trending down for several weeks. We also have maintained a small supply of remdesivir at MDH to send out to hospitals if needed, but we've only had to do that on a couple of occasions. I also want to just comment that it's really been terrific, another good example of collaboration among our health systems, to see how well the healthcare community has worked together to make sure that patients have access to this trial drug. We have reached out a few times to individual hospitals that have surpluses of remdesivir to request that they send some to others that are running low. And without fail, everyone has said yes every time and emphasized that they're happy to share and to help their colleagues. So with that, I will turn it over to Kris Ehresmann to talk about a couple of issues, and then I'll be back. Kris?
Thank you, Commissioner. I'd like to start by talking a little bit about testing. The Commissioner talked about the increase in testing, which is great. But one of the things that we have been seeing is some delays in getting testing results. So earlier this week, we discussed some of the challenges related to COVID testing, given the increasing disease activity that's occurring nationally. So that puts a strain on our national laboratories. We've been hearing that many of the national laboratories are having delays in reporting out their results. This is obviously frustrating, but it's very important that if you are symptomatic and are waiting for test results that may be coming from these laboratories, that you continue to stay home and do not go out in public until you get those results. I realize again that this is a really frustrating situation, but we have been saying for months now that people who are sick should stay home, and certainly if you're symptomatic and thought that it was appropriate to get tested, it's really important that you continue to shelter in place while you await those results. We've also been hearing from health systems that some individuals are seeking COVID testing every couple of days. With the exception of certain situations, serial testing of a single individual is really not recommended. Testing is not a substitute for masking and social distancing. So we really, as much as we're encouraging people to get tested when it's appropriate, getting tested over and over again is not necessarily the appropriate use of that resource. And I know health systems are working to address that within their systems. Then for a change of pace, I wanted to bring up a topic that had nothing to do with COVID, but rather is related to the warmer weather that we're experiencing. Given that we've seen prolonged periods of warm weather, I wanted to bring to your attention the risk of Naegleria fowleri infections. You may recall that Naegleria causes primary amoebic meningoencephalitis, sometimes referred to as the brain-eating amoeba. This amoeba is commonly found in fresh water and soil and infects people when water containing the amoeba enters the body through the nose. The amoeba then travels up the nose to the brain where it destroys brain tissue. Naegleria fowleri, this amoeba, is found worldwide, and in the United States, the majority of infections have been caused by fresh water in the southern states. But in the last number of years, we have seen infections in the north following periods of very warm temperatures. While the infections are rare, they are more likely to occur when it is hot for prolonged periods of time, which results in higher water temps and lower water levels. So I wanted to make you aware of this because we are experiencing unseasonably warm weather in Minnesota. Swimmers should assume that Naegleria is present in fresh water. To reduce your risk, keep your head out of the water, hold your nose shut or use nose clips if going underwater, and avoid digging in or stirring up sediment. And then finally, I wanted to give you some updates on the long-term care data that we publish on our website. We have been posting a list on our website for a number of weeks of congregate care facilities that had reported a COVID-19 exposure at the facility. The exposure could be from someone who either visited, worked, or lived at the facility while contagious. Up until now, we've been updating this list daily, and once a facility was added to the list, they stayed on the list. However, starting today, we are going to update this list weekly on Fridays, and there is a process for facilities to be removed from the list if they have not reported a new exposure for a minimum of 28 days. 28 days represents 2 incubation periods for COVID. If a facility identifies a new exposure of COVID-19, they will once again be listed on the website. If the exposure was because a resident was sick, the 28 days starts from when that person was put in COVID-19 precautions, meaning they were isolated and other recommendations were implemented to stop spread. If the exposure was a staff or visitor, the 28 days starts from the last day that person worked at or visited the facility while infectious. We know that facilities are working very hard to prevent exposures by implementing screening and infection control practices, and we know that they are working very hard to control spread if an exposure does happen. As facilities are able to offer more visitation opportunities, it's important for all of us to do our part and follow recommendations of wearing masks, not going to a facility if you are sick, and keeping distance between people. Working together with facilities will allow us to protect these vulnerable populations. And with that, I will turn it back to the Commissioner.
Thanks, Kris. Well, as Mike Schomer said in introducing the call, we're able to share with you today a really positive step forward in making some changes to the visitor restrictions that have been in place in long-term care facilities since the middle of March. This has been difficult but very essential to help protect the vulnerable people in these settings, as well as the staff, from the risk of and the spread of COVID-19. These restrictions have really been helpful in reducing the spread of COVID-19, but as we've discussed, and we've certainly heard from providers in the facilities, as well as from residents themselves, from loved ones, families, that these restrictions have come with their own cost, in the form of certainly social isolation, loneliness, the very real health risks, as well as quality of life risks that this provides for loved ones and families at what couldn't be probably a more stressful time for everyone. Balancing safety from COVID-19 with the well-being of residents is an urgent priority for all of us. And with that in mind, we at the Health Department have been working with stakeholders over the last few weeks to develop some new guidance for long-term care facilities to use, in this case, in designating family members or others to serve as what we are referring to as essential caregivers for residents in long-term care facilities. As you know, we have also been working and have released window guidance and outdoor guidance, window visits and outdoor visit guidance in recent weeks, and we continue to actively work on broader guidance that will allow some further expansion of visitation and activities for residents, and that will be forthcoming in the coming weeks. But we're happy today to be able to move forward on another important piece, which is that people designated as essential caregivers, designated by the residents, and through a process, will have expanded access to help ensure that the residents' full range of emotional, social, and physical needs are met. Now, it's important to note that this guidance does not include all visitors who wish to visit who may not meet the guidelines for an essential caregiver. And as I mentioned, the in-place window visit guidance and outdoor visitation guidance are intended to support these more casual visits and other visitors. But an essential caregiver is a family member, an outside caregiver, a friend, or a volunteer, someone who has provided regular care and support to the resident before or during the pandemic. Residents can have more than one essential caregiver for providing emotional support and individualized person-centered care. The guidelines require caregivers to sign in and be screened prior to entering the building, just like facility staff do. Caregivers must closely adhere to important infection control procedures. They must frequently wash their hands and use hand sanitizer. They must wear all necessary personal protective equipment while in the building. This minimally will be eye protection and face masks. We encourage testing on all fronts, but at this time are not requiring testing prior to entry as an essential caregiver. But as mentioned already, the caregivers need to go through health screening prior to entering, such as other facility staff and essential healthcare workers do, as well as those currently visiting for compassionate care visits. Again, I just want to stress how important it is that careful infection control practices and PPE use must be followed by essential care providers at all times. While preventing the spread of COVID-19 among residents and staff of long-term care facilities has been a very top priority for all of us since the start of the pandemic, we do recognize how important it is to ensure that the social and emotional needs of residents continue to be met. By rolling out this guidance, we hope to build a more robust framework that providers can use to ensure that their residents' needs are met. We're extremely grateful to our partners who helped develop the guidance, including the folks on the call today and many others. I'd like to introduce them again in order, and I would first ask Cheryl Hennon, who is the state's ombudsman for the Office of Long-Term Care, to make some comments. Cheryl.
Thank you, Commissioner Malcolm, and I sincerely appreciate this opportunity to talk with all of you today. I want to acknowledge the importance of we are all working together to get to this point. I feel that speaks to the strength and the commitment of citizens in Minnesota, and we need to continue to show how we do this in Minnesota in terms of supporting rights and well-being and considering persons, people first in our regulations and guidance. People are suffering and they're dying from COVID-19, but also from loneliness. They're emotionally wrought. Families are experiencing or seeing conditions deteriorate, whether it's by the phone or FaceTime or through the window. They're seeing their loved one become unresponsive, unable to respond to basic conversations. We all agree visitation restrictions were implemented for good reason. Persons living in long-term care settings, our everyday heroes, are at particular risk of complications from COVID-19 due to their age, underlying health conditions, and congregate living situations. However, the Ombudsman's Office, in our role as advocates, we, as time has moved on with this virus, we have increasingly experienced, by walking at the side of people who live in our long-term care settings, members of our communities are calling us and talking about the psychological and physical decline of their loved ones. So imagine this for a moment. You have a partner, a loved one. You've been with them for 57 years. You've always been together. Unfortunately, your loved one that you've laid beside, spent fun times with, all of a sudden, unfortunately, is diagnosed with dementia, and the condition continues to advance. Therefore, the tough decision is made to move into a long-term care setting. With COVID-19, what we see, and it oftentimes feels like in many ways we're working at ground zero, but we do see blessings happen where due to the restrictions in visitation and the separation of people, behaviors increase in the individual, people stop eating, people are not sleeping, people are not bathing, people are totally refusing. They feel they'd rather be leaving the earth. So family members and people are contacting us. Imagine you are in their place and you realize that you are losing your loved one. We have heard from facility staff members tell us, please help us, because in our opinion, in our medical opinion, this person is continuing to experience significant decline because they are not with their loved one of 57 years. So not giving you private information, this is actually a regular, or it's also an example of a family that we've worked with. We were able to obtain a visit for this particular individual because of the significant decline. And the family member had been providing regular cares for their loved one prior to the person entering a long-term care setting. So with the cooperation of the facility, the loved one was reunited with their spouse of 57 years. And it was incredible, the increase in positive mood. The resident was motivated, engaged, was eating, was bathing. The point I'm making is this essential caregiver guidance is very significant. And the Ombudsman's Office is able to be available to assist in making sure that we accommodate the guidance, that we work with facilities. We also are very grateful that the guidance reflects a person-centered, person-focused guidance criteria. If you look at it, you will see that the guidance is, the person-centered direction is explained in promoting quality of life. The resident is given choice in determining who they will designate as an essential caregiver. The point is, I appreciate the work that was done collaboratively with stakeholders in reflecting the importance of the person at the center of the guidance. And I can assure you there will be a number of people very, very grateful that this is happening in Minnesota. And we in the Ombudsman's office do stand at the ready to assist in ensuring that we can bring people together again, and of course within following proper procedures and precautions. I just am very grateful to see this guidance now issued. Thank you, Commissioner Malcolm.
Thanks, Cheryl, and thank you to you and your colleagues in the Ombudsman's office for the critical work you do all around our state every day. Now I'd like to introduce Gail Gvenvold, President and CEO of Leading Age Minnesota. Gail.
Thank you, Commissioner Malcolm. As providers, we've been so pleased to collaborate with the Minnesota Department of Health and the Ombudsman and other stakeholders on this exception to visitor restrictions for essential caregivers. Before COVID-19, families and loved ones were an active presence in the lives of our residents and played a critical role in the quality of life in our settings. And we regard them as part of our caregiving community. And while we've made every effort during COVID-19 to continue to engage those families and caregivers virtually, we know and we see every day that prolonged physical separation takes an emotional and psychological toll, as well as affecting overall health. So we will proceed with an abundance of caution because we know we are still very much in harm's way from COVID-19, and the guidance reflects that continued vigilance with screening, strong infection control, and appropriate limitations. But we believe this is absolutely the next right step to reconnect residents with their loved ones while still making safety a priority. And we know, too, that families are eager for this opportunity, but we appreciate the opportunity and the guidance for each care community to use the next few days to get their plans and precautions in place. And we, too, call on all of our colleagues and friends in our greater communities to help us make this successful with those behaviors that reduce the spread of COVID-19, wearing masks, social distancing. The better we do in our broader communities, the better we will do with safety in our care settings as well. Thank you, Commissioner Malcolm.
Thanks, Gail, and I appreciate you reinforcing that point about just how critical it is that we continue to work hard to reduce the community spread of COVID-19 in every way that we can to support this important continued focus on people in our long-term care settings and to support the reuniting of essential caregivers with their loved ones. And now I'd like to introduce Patty Cullen, President and CEO of Care Providers of Minnesota.
Thank you, Commissioner. And I'm just going to repeat just a couple of things that have already been said and kind of end with a little bit of heads up on the complexity that we're looking at here. We know it's been a long 4 months for our residents, for our essential caregivers. It seems like it's 4 years for all of us involved in this. We hope that this designation just reflects kind of another turning of the dial to go to kind of what Minnesota is known for in terms of turning the dial. We've turned the dial to allow compassionate care visits right away. We turned the dial to allow for outside window visits and now outdoor visits. And this is kind of the next step in the progression. It is not intended, as Commissioner Malcolm said, for everyone, that the door is wide open, come on in. We are not at that stage yet until we get widely available testing and other tools like available PPE for everyone. And until we get that systemically, we are not ready to turn the dial even further. But we appreciate what this step will allow in many of our communities. We also really appreciate the fact that if you read the guidance, you have to probably get to the third page or second page to get to the implementation date of July 25th. And family members, as soon as they saw this posted, have started asking, can I come in right now? Can I come in right now? We need to make sure we do this right so that we are not closing the doors again. So what we're trying to do is do this balance between what do these individuals need, as Cheryl so eloquently said, yet protecting all of those who we have worked so hard to protect in our settings, our residents and our staff. Minnesota looks pretty good right now in our settings. We have a lot of cases where we don't have any COVID, and we have a lot of communities where there's maybe one case. We've worked really hard in infection control and in protection, and we do not want to have all of those really strong efforts go to waste with not doing this right. So the policies that will have to be developed before this can be implemented are very complex. I mean, not only do we have to review every person in our building to take a look at the person-centered plan and do they have a caregiver, but we have to set up the systems for the screening, for the PPE. We have to make sure that there's training so that there's an understanding of as a visitor what the expectations are. You know, you go right to the room. You have to make sure that you don't do what you used to do. And that's really hard to unlearn when you've had family members who have been very good about visiting neighbors and friends and going to open spaces and being very social. We're not going back to that normal, and so retraining is going to be a critical part of this. And finally, helping them understand that we have to just follow the data like everyone else is in the state, and we have to watch closely what triggers would it take for us to say we have to stop these for now. And that's what we are trying to avoid. It's one thing once you open the doors. It's going to be very difficult to say, I'm sorry, we're going to have to stop doing the visits that you've missed so much. So we want to be very cautious about this. So the message I would give to family members and everyone else out there is we know you've been patient for 4 months, and we're begging you to be patient for a little bit longer while we put in place. Again, providers are just seeing this guidance today for the first time, and they're going to need a little bit of time to gather their people together and figure out how they can implement this with safety in mind. So with that, I guess I turn it back to you, Mike, for questions.
Great. Thank you, Patty. Yes, operator, we're ready to take questions now.
As a reminder, to ask a question, you will need to press star 1 on your telephone keypad. Please stand by while we compile the Q&A roster.
Operator, any questions at this moment?
We have no questions at this time.
Okay, we'll pause for just a moment. See if any reporters on the line would like to ask a question. Could you just remind them of the guidance?
Okay, to ask a question, you will need to press star 1 on your telephone keypad.
Still no questions?
And we have a question. First question comes from the line of Emily Havoc. Your line is open.
Hi, thank you. Just a heads up, I had punched in a few times. I think there might be something glitching with the questions. I'm guessing other people have too. My question, I'm sorry, I'm actually going to go off topic a little bit here because my question has to do with young people in COVID-19, not young adults, but kids up to 19 years old. I was kind of digging into those numbers for the past couple months, and it looks like the percentage of cases in Minnesota that are people 19 and under has actually doubled in the last 2 months. The weekly report for May 14th said it was just over 6% of cases, and this week it's over 11.5%. Just wondering if Jan or Kris, you could contextualize that increase for me at all. Is that surprising to you? And does that probably have to do with testing a lot more young people, or do we think that we're seeing a real increase in cases among kids? I know we've been talking about that a lot in the news the last couple of weeks.
Thanks for that question. I think you are you're reading the data correctly, but I'm going to ask Kris to kind of give some context for that.
Yes, I think that the increase that we're seeing in not our young adults, but in our youth, is a combination of both of those things. That testing is more available. As you know, when we had limited testing, we really focused on our elders because they were our most vulnerable populations, and so that was where our testing resources were invested. And now that we have adequate testing, we are able to be testing everyone who's symptomatic. So I think that is a factor. The other thing is that we have moved away from, shelter in place. There's a lot more activities and a lot more interaction for our youth, and so that too will contribute to increased transmission and identifying more cases. So I think it's a combination of both of those things. And so it's just a good reminder, we want you to be able to participate in your sports. We want you to be able to, interact, but please do so in a socially distanced manner.
As a follow-up here, can you tell me what you're seeing in the contact tracing? I know we had talked about Edina before being related to house parties, cabin gatherings, youth sports. What are you seeing statewide?
We're seeing that same thing statewide. We've I think on an earlier call this week, I talked a little bit about what we were seeing, related to child care and things. But because we're seeing an opening up of multiple activities in which kids can participate, it's those things. It's sports. It's, those various interactions that are contributing as opportunities for transmission. So no one thing in particular, but all of those activities.
And are you seeing any hotspots or clustering with these cases among kids besides what we already talked about with Edina?
No, not in particular.
Thank you, Kris.
Your next question comes from the line of Liz Collin from WCCO TV. Your line is open.
Thank you. Yeah, and I have punched in a couple times as well, so just not sure if there's an issue with questions. But maybe this is a question for Kris. You were mentioning earlier, as you have earlier this week, about this delay in test results, Kris, due to these surges across the country. Do you know now how long Minnesotans can expect to wait for results? Do you have an actual number of days on that point, and do you see that wait time improving at all in the near future?
We don't know for every laboratory. We've heard for some labs it can be as long as a week and a half, which is really a frustrating time frame. Usually with the labs in Minnesota, we're seeing, a pretty quick turnaround. Even some of them have found that it's taking, a couple of days as opposed to 24 hours. But I think that, people should be aware that if they haven't heard back, certainly they want to check in to make sure they haven't missed something. But to keep in mind that the delay in hearing results is because of what we're seeing that's going on nationally as well. So people just need to keep in mind that it could take a while for them to get the results back.
And Kris, just to clarify, it's a testing supply issue and also a lab capacity issue. Is that right?
Right. It's a combination. I mean, as we talked about months ago, there were great demands on the system, and that impacted all of us. And there's been a lot of changes made. We've done a lot of things in Minnesota to make sure that our capacity is greater. But with the increased demands on the system in the United States, that puts a demand on the national labs, and that also puts some demands on some of the supplies and things like that. So it's a combination of factors, but the ultimate outcome is that there have been more delays. And we just wanted to alert people to that because it's really important that if it does take quite a while for you to get your results, that you are not circulating in society. Because we would be calling you, if you had your positive result, we'd be calling you to tell you to stay home. And so we're telling you that now. Please continue to respect that even as you're having to be patient about getting results.
Thank you, Kris.
Next question comes from the line of Bill Werner from Minnesota News.
Hi,
Commissioner. Open.
Thank you very much. Pardon me. Commissioner, just to switch topics a bit, there's going to be a bill introduced by Republicans in the Minnesota House on Monday, assuming that the governor calls a special session then, that would allow school districts to make a decision on what happens as far as their students this fall, whether they be back in the classroom or they continue distance learning or a hybrid approach. Your thoughts on that? Is that appropriate at this point in time?
Well, I would probably want to refer you to the Department of Education for just better insight into how that partnership between the State Department of Education and local school districts and jurisdictions works. We think it's certainly important and appropriate that there be guidance that is available and used to the extent that it is possible statewide for having as much consistency as we can in approach, but local conditions do differ. And I think what you will see in the guidance when it is released by the Department of Education with consultation from us at the Health Department is, and we've been reinforcing the value and the appropriateness of everybody having all three plans fleshed out: in-person learning, distance learning, and a hybrid model, because I think as Commissioner Ricker has said, as well as we had said at the Health Department, it's highly possible that districts may find themselves using a combination of approaches during the year, because there will be, as a part of that guidance, assistance for districts, school buildings and school districts to really understand the criteria that might make them switch between models. So we've been talking about, you're aware, we're working on that guidance right now. So we believe that guidance will be available to schools to support their planning in the near future.
Commissioner, just a quick follow-up. Will that guidance reflect then regional options? In other words, not necessarily the same guidance for all school districts in Minnesota, regardless of where they're located?
Well, again, I'd refer you to the Department of Education for any nuances that I may be missing there. I think the approaching this as sort of a statewide goal and a statewide strategy, but with again with guidance as to the factors that might lead to some tailoring of which models in place at which time based on local conditions.
Okay, thank you, Commissioner. Appreciate it.
Next question comes from the line of Catherine Richard from Minnesota Public Office. Your line is open.
Hi. So we have had our data reporter punch in the numbers you release every day to kind of give us a sense of where there are some trends, and it looks like there could be an increase in the metro suburbs, and I'm just wondering if you guys are noticing anything there and can tell me what's behind that.
I'll ask Kris to take that one.
Yeah, there's nothing in particular. We talked. You probably heard we talked about what was happening in Edina, with youth in Edina, and that's been on previous calls. But we haven't. There's nothing that's come up in our daily briefings to talk about anything in particular in those areas. But certainly, we're seeing increases due to, people frequenting bars and restaurants and more opening up. So that those may be factors, but I don't have a specific hotspot answer for that.
Sure. And on that note, yesterday, public health officials down here in Rochester said that anyone who was out at a bar between June 26th and July 7th should get tested, but I've been kind of vague on the details around that. Is there anything more you can tell us about the situation down here, and are you looking at Olmsted County as a potential hotspot as we continue to see people get tested?
Yes, we are working with Olmsted County. They have been doing many of the case investigations, and so they're the ones that are working, specifically on what's going on in the Rochester area. We have some criteria that we use before we release information about a facility. We want to make sure, well, first of all, we want to make sure they've been notified, but then also that we have seen at least 7 cases that are associated with that facility that have no other, so that only frequented that facility. I can check and see where we are with the numbers on that and send you an email with the names if we have reached the point where that's where they're at.
Okay, and are you seeing any indication here that Rochester could be another hotspot? I think they reported, 39 new cases overnight, which is, as far as I can tell, the most reported in a single day period.
Yeah, certainly we are concerned, and that's why Olmsted County wanted to make sure that people were aware of what was going on. We're concerned when we start to see clustering of cases related to establishments, and what we're learning is that people don't just go to one establishment, but they may go to one and then move to another. And so I know Olmsted was really looking at a particular geographic area where people were going in and out of different establishments. So I'll check on the details, but yes, we are concerned, and that's why Olmsted put the word out about that. And we supported them in doing so.
Okay, thanks.
Next question comes from the line of Kris from KARE 11. Your line is open.
Hi, thank you very much. Perhaps this is a question for Kris or Commissioner Malcolm. I want to ask you about this letter that was sent by 239 scientists, really to health departments around the world. And it was enough to convince the World Health Organization to at least open up the possibility that SARS-CoV-2 is transmitted through aerosols. So basically the letter says, evidence has demonstrated beyond any reasonable doubt that viruses are released during exhalation or just breathing, which is a far further leap than what we have been, I guess, advising and telling folks. And they say that risks of exposures now go beyond 1 to 2 meters, and that small particles 5 micron in size can spread 10 meters indoors. So my question is, what are your thoughts on these revelations? And do you think that they should alter Minnesota guidelines for all indoor activities?
This is Commissioner Malcolm. I'll start, but I'd like Kris to comment as well. Certainly, I think we've said since the beginning that we are, it seems like daily, humbled by what we don't know about this novel virus. And a number of really core assumptions have changed over time. So it's critical that we stay open to the evidence as it emerges and be willing to relook at our guidance and our policies. I think we've said all along that there is no one single magic protective factor. It's not masks, masks no matter how close you are. It's not, only distance. It's congregations of people. It's large gatherings. It's proximity. It's duration. It's type of activity. And I think we've known since early on with some of the church-related outbreaks and other things that close proximity and singing and loud speaking, it's been clear for a while, has its own unique risks of transmission. So this latest data is certainly important for us to fully understand, and again, things just do continue to evolve week over week. So, Kris, I'd like you to chime in.
Sure. Thank you, Commissioner. Yes, I agree with what the Commissioner is saying, that we are continuing to learn new things about this virus. We have talked a bit about aerosols and certainly about the risk of aerosol generating procedures. Those are things that happen in the healthcare setting, so less on public calls, but those are things that we have been concerned about. And I think, when we talk about this kind of information, we've been discussing the value of masks and how we really encourage people to wear masks. And we talk about the fact that wearing a mask serves as sort of source control. And what it helps to do is it helps to trap and reduce the spread of those aerosols. It's a bit of a barrier. So I think that's one thing to keep in mind, is that our guidance on masking, while we're not looking at personal protective equipment for our individuals and the general public, but that masking helps to address some of those issues related to aerosolization of the virus. And then I think the other thing is that these are new data, but I can tell you that the data that has looked at what helps to reduce the spread of COVID, that 6 feet still makes a significant difference. And then certainly as you get farther and farther apart, you see even less spread. So the data that we have does continue to support that even the 6 feet that we're currently recommending makes a big difference in reducing spread, and we'll continue to work with our partners at the national and international level to evolve and to revise our guidance for people. But just to know that the data that has looked at the guidance that's out there shows that what we're currently recommending still makes a difference, even as we're learning new things about the virus.
So just to clarify, so I get you're saying that the precautions that you're already putting out there should pretty much cover, aerosolized spread if it does come just from breathing. Social distancing and masks are still the same preventative measures. But I guess I'm saying, are you willing to tell the public are you willing to acknowledge that far yet, that breathing could be a sole source, not just coughing, sneezing, and singing and talking loudly, but just breathing could be a source of transmission?
Yeah, I think that's why we've talked about the need for these various measures, is because that is a factor. We've certainly said that if someone coughs on you, that is definitely an issue, because you have a much greater potential for greater viral exposure. But certainly the idea that the virus can be, in someone's breath is something that we have talked about, and that's, again, why we're recommending the masking as well as the social distancing. And as I said, that's not to say that as we get more information and as we're talking about these data more, that we may not make modifications, but I just wanted to encourage people that the data that has looked at the impact of social distancing does show that when you are distancing, that makes a difference in reducing transmission. And of course, the farther apart you are, it makes a greater difference.
Operator, we have time for one more quick question.
Understood. Your last question comes from the line of Steve Karnowski with Associated Press.
My question here, just going back to the main topic today about the new guidelines, with your positivity rates increasing, is this a good idea?
This is Commissioner Malcolm. I'll certainly take the first crack at that. As I think several of our speakers said, we absolutely acknowledge that this move to allow, again, essential caregivers who are so important to the health and emotional well-being of the people to whom they are so important. We acknowledge that this is happening within an environment where there is still risk. But we believe that we've got certainly much better tools in place today than we did 4 months ago, with a testing regimen, with better supplies, not perfect by any means, but much more attention to the supply of personal protective equipment for folks in long-term care settings, much enhanced infection control procedures. So it is certainly, while being mindful, and as I think Patty Cullen indicated in her comments, this will have to be. This is not going to be something where a facility puts in place a process and then it just stays without revisitation. If there are significant outbreaks in a community, that would be reason why a facility might have to suspend this essential caregiver policy for some period of time. So we are going to be very much mindful of the situation statewide and locally for making sure that we can maintain this appropriate balance between safety and increasing supports and choice for residents and families.
That's all the time we're going to have for this afternoon's call. I know we covered a lot of ground. If we weren't able to get to a question, please feel free to reach out to the MDH Communications Office this afternoon. Thanks again, and we'll be with you again Monday.
Ladies and gentlemen, this concludes today's conference call. You may now disconnect. 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 You may now disconnect.